Okay? Is it okay if we start? Or
Yes, yes.
so, a very good evening to all of you. I invite all the faculties. Basically, we have two distinguished faculty today. One is Dr. Basu, he is from Calcutta, and another is Dr. Bhaukar, he is from AIMS Delhi. Dr. Basu and Dr. Garg, both are, welcome. And Dr. Bhauk has also joined. I'm able to see him here. Hi, Dr. Bhauk.
Thank you, sir.
So I welcome all the participants and the faculties to this very promising academic session of GAPIO. And we have a very interesting session of deformities. So basically, Dr. Somajit Basu is the first speaker and first faculty who is head of spine services in Kothari Medical Center. And actually, he doesn't need any introduction now. At present, he is the president of Association of Spine Surgeon of India, and he had headed even the West Bengal Spine Society. He has a lot of work in spinal deformity. He is in the very active member of SRS, and he is going to talk on adult spinal deformity. So, Dr. Basu, you can start your talk. Welcome.
Thanks, sir. I'll just share my screen. So am I audible and visible?
Yes, yes.
So thank you for giving me an opportunity to present my work on adult degenerative scoliosis. I'll talk to you about the Indian perspective because this is, as I understand, it's a Association of Physicians of Indian origin. So it's nice to get an opportunity to share with you the Indian experience of adult degenerative scoliosis. Here are my disclosures. So we'll be basically restricting our talk to type 1, which is adult degenerative scoliosis. Adult scoliosis was classified way back in 2005 by Max Aby and his colleagues, in which there are three types basically. Type 2 is basically a progression of idiopathic scoliosis, and type 3 are secondary curves due to other disorders, for example, neuromuscular congenital scoliosis or metabolic anomalies. So I'll be restricting my talk to adult degenerative scoliosis, and we all know it's a coronal plane and a sagittal plane deformity. More often than not, it's the sagittal plane which matters most, and imbalance is basically due to focal causes, regional, and global. So the perspective of the imbalance has to be visualized in the understanding of focal, regional, and global issues. And we know that in AIS, the prevalence is less than 2 to 4% of screened pediatric population. In our country, I believe it is much less. We do not have strong data to support this, but I think it should not be more than about 1 to 2%. Whereas in adults, we have a lot of published data to show us that more than 60% of screened elderly population beyond 70 years of age has a significant adult degenerative scoliosis. Now, I will not go into the classification of the same, but it's just important to realize that the SRS Schwab classification has basically two parameters to be considered. One is the coronal curve type, and the other is the sagittal modifiers. As I already told you, that the sagittal modifiers are more important, and the tripod of the sagittal modifier stands on the PILL mismatch, which, as we all know, it's usually between 9 to 11 degrees normally. There is a concept of global malalignment in which the sagittal vertebral axis is either less than or equal to or more than 5 to 7 centimeters. We say 0 is less than 4, plus is 4 to 9, and more than 9.5 is plus plus. And the other parameter is the pelvic tilt, which is usually less than 20 degrees. Now, other than these three sagittal modifiers, we have the coronal curve lines, which is basically thoracic, lumbar, and double curve. And if you look at, there is one particular aspect in which it's a normal coronal curve. That means there is no coronal curve, it's only a sagittal malalignment. So once again, these are the three sagittal modifiers: the PILL mismatch, the global alignment, that is the SV80, the sagittal vertebral body axis, deviation, and the pelvic tilt. Now, if you look at the impact on the health care or the health related issues in the world, it is huge. In the teeming millions of our country, we just can't say no to them. We have to take care of them because it is a very significant disability. And all the health research states that if you see the impact of other health related issues, for example, coronary arterial disease and hypertension, diabetes, this study came out with 25,000 people studied from 8 countries with arthritis, COPD, diabetes, and chronic heart failure. And they were compared with adult scoliosis in the terms of SF36 and ODI scores. And we found that adult spinal deformity has a significant and measurable impact on the health and quality of life. The impact is more significant than other chronic medical conditions. So we have to understand that it is an extremely resource sapping disorder of the elderly population. And if this is not taken care of, it will be a real disability to many elderly patients. So if you look at it is whether it's a natural process of aging or it's a pathological process. The aging spine, as we all know, goes on into disc degeneration, MRI changes or modic changes. 50s and 60s, you have facet degeneration, and ultimately it might lead to a stable spine in ankylosis, or it might be an unfavorable degenerative cascade in which we have stenosis, spondylolisthesis, deformities, which ultimately leads to adult scoliosis. Now, all curves progress to a varying degree, estimated to be about 2 to 3 degrees annually. Factors influencing curve progression include cob angle more than 30, lateral listhesis more than 6 millimeters, apical rotation more than grade 2, and the L5 below the intercostal line. So where does the pain comes from? The pain basically it comes from 3 areas. Either it is the curve proper, or it is the low back pain disc degeneration, or it is radiation because of stenosis. And the 3 areas which determine this pain are, of course, scoliosis, disc degeneration, and stenosis. And it encompasses all spinal disorders that involve a malalignment in respect of global, regional, segmental level. And if you look at these particular CT scans, you will understand that it is not only a patient who has a segmental disorder in this particular CT, but we also have to understand in wake of the entire spine, and the malalignment has to be noted accordingly. We all know that John Dobusche had introduced the concept of conus of economy, where the body can stay within the surface with a minimum of muscle action. So, deviation from the stable zone. So, if you consider the feet to be at the apex of an inverted cone and the head beyond the cone of economy, in that case, this patient on walking and on standing spends a lot more of energy than is tolerable. And so, once they start to walk or stand for some time, they start to have respiratory distress. And this loss of global alignment means that there's an anterior plumb line shift, and this anterior plumb line shift or the lumbar kyphosis has been extensively studied by our teachers like Steve Glassman, Keith Bridwell, John Dimer, and Frank Schwab. And we found that full-length AP standing X-rays is extremely important, and the pelvic parameters such as incident and tilt can help define the compensatory mechanisms of deformity. Now, here is a patient whom you see that the spine is well balanced after the instrumentation. And these patients occasionally need advanced imaging like MRI or CT needed for patients with lower extremity symptoms. I will not go into the details of the spinal parameters. We all know that thoracic kyphosis, lumbar lordosis, C7 PI, mismatch of the C7 plumb line, the pelvic tilt, and the sacral slope are important, but we need to realize that always pelvic incidence is equal to pelvic tilt and sacral slope together. I'll go on to a clinical example. You see this patient has a 2-level stenosis, and the L4 and L5 is kyphotic. So restoration of these patients means not only a sagittal balance, but also a good coronal balance. So the next issue is when to operate on these patients. Now, you see, there it's a wide spectrum. How can we select the best patients in the Indian perspective? Can we predict who have a successful surgery? At one end of the spectrum, we have somebody who is definitely not going to improve, and on the other end, there is a sheer success slot. But what happens in between is something which is extremely important to consider, and we know that a good candidate for surgery is a perfectly isolated pain generator. He is well informed, wishes to pursue operative care, excellent health otherwise, realistic expectations, are highly motivated, and the team must have an abundant experience, and only excellent results with planned intervention can occur. Whereas it is not a candidate for surgery in relatively young patients who doesn't want surgery, unlikely to survive surgery because of severe comorbidities. He doesn't understand or doesn't have a realistic expectation to surgery, and a planned operation is not recommendable because the experience, team, environment is not up to the mark. So, in this situation, surgery is indicated in adult spinal deformity in back pain, which may or may not be radiating to the legs for stenosis, and it is indicated only when prolonged conservative care fails, and it is rarely indicated for only back pain. Now, the strong clinical radiological correlation is very important. If there are neurological deficits or there is a progression of curve more than 10 degrees, and if there is a curve angle which more than 30 degrees or more than 7 millimeters of lateral listhesis, we need fusion surgeries and deformity correction surgery. Decompression can be added when there is neurocompression and leg symptoms. Now, what are the levels of operative treatment, right from decompression to osteotomies? If you look at this particular patient who needed a very simple posterior decompression, the typical Christmas tree operation, in which the roots are freed and decompressed at each level, this is a very simple surgery, and this surgery may be extremely complicated on the other end of the spectrum, in which a patient might require a major osteotomy. For example, in this patient who had a posterior subtraction osteotomy. This is actually a pedicle subtraction osteotomy. This is extended pedicle subtraction, more like a coronal osteotomy, in which you can find that not only the coronal but also the sagittal parameters are so well corrected. Now, what happens in between is there is a significant number of patients who require both a lumbar and a thoracic fusion. These are patients who require a huge surgery and they may not be the best of candidates. So it's extremely important to choose a proper patient. For example, this patient who required a T2 to pelvis fusion. Now, the rest of these patients who have limited fusion options available, and that is where the scope of limited fusion is there. And this is the proper Indian perspective in which we aim for a lesser surgery with the maximal benefit. So, isolated radicular pain with a small lumbar curve, elderly or medically unfit patients, they can go away with a single or a two-level fusion only. For example, in this patient with a two-level stenosis, as I had alluded to earlier, required only a two-level fusion, and this fusion restored reasonably well its coronal as well as sagittal parameters, as you can see. So, minimal intervention is required for these patients, which gives an optimal end result. Now, what should be the levels of fusion? Usually, a T10 to pelvis is done because T10 has ribs, and occasionally T11 and T12 may be also indicated. Now, whether to stop at L5 or S1 is a bit of a debate in which you can stop at L5, but most of the times, if you have a fractional curve more than 15 degrees, an oblique L5S1 takeoff, an intervertebral disc degeneration, or a L5S1 spondylolysis, then it's better to include this particular segment also. Junctional kyphosis, lateral subluxation is better included in the fusion. Now, there are huge minimally invasive surgical deformities options which are now available, and the MIS algorithm has been widely recognized worldwide. The conventional approach should be used for deformity correction for only the class 3 patients. Now, let us look at what are class 1, class 2, and class 3. This is the MISDEF classification, which is basically accepted worldwide. In class 1, there is a decompression only or fusion of a single or two levels. In class 2, decompression interbody fusion of the apices of the curves And in class 3, they require a very major osteotomies. So in this category of class 1 and class 2 patients, I'll give you an example. For example, this patient who had lateral recess stenosis at 3, 4, 4, 5, and 5, 1, we did a 3-level olive with a 4-level fusion. So you can see L2 to S1. The L5 S1 fusion I did from behind with a missed leaf approach, and the others I did a olive approach. And if you can see the excellent restoration of the lumbar lordosis, which was not there to start with, shows you that the results are clinically quite good. In these patients, the further classification has subclassified into 2A and 2 and 3. I'll not go into the details. Now let us look at this particular patient once again. As you can see that there is a significant sagittal vertebral axis deviation of 65 millimeters. And on this patient, a simple surgery of L2 to S1 could restore not only his corner but also his sagittal parameters. And this is the pre and post-operative sagittal parameter correction, which you can see. The patient is standing upright with a reasonably good restoration of the SVA along with the reasonable restoration of the PILL. Occasionally, they can be staged. For example, if you have a patient who has a 2 or 3 level olive done in the first stage with anterior column reconstruction, the second stage involves a posterior minimally invasive surgery. So this reassessment done after the first surgery, in which the patient is allowed to walk for 3 to 5 days and then get back for the second stage surgery, leads to downgradation of the MIS stage. For example, initially maybe it was class 3, and after the first surgery, after putting in a couple of cages or 3 olive cages, you might see that the patient has downgraded. So in this typical patient, you could see that there was a significant stenosis, lateral recess stenosis at 3, 4. And so we initially had a angle of 39.7 degrees with a significant PILL mismatch. And surgery was done in 2 stages, 5 days apart. So this was the first stage surgery in which we put in olives at 2, 3, 3, 4, and 4, 5, and then allowed her to walk. We did have some restoration of the lumbar lordosis. And then why? Next stage, we did a T10 to S2. And you can see that gradually the patient improves on his curve at the end of 12 months. So this is the pre-op, and after the first stage, after the second stage, and that's what after 12 months of follow-up. So she's still reasonably doing well, and she's now 3 years follow-up. And this is the coronal parameters, which are also getting corrected, but it's important to remember that this is much less important than the sagittal parameters. I'll last go on into the complications of adult deformities, because there are numerous complications of adult deformities like instrumentation failure, pseudoarthrosis, neurological deficits, infection. But the most important complication is medical complications. They have a host of pulmonary issues, DVT issues, hypertensive, diabetics. Many of them have muscle atrophy, nutritional imbalance, wound healing problems, and it just goes on. So if you look at one of the saga of complications of this patient who started off with a single level L5S1 fusion, went on to L3 osteoporotic collapse, for which a vertebroplasty done, which again led to a junctional kyphosis and extended it to T12, a T10, and then she again did well initially, but then again went on to have junctional kyphosis, which became symptomatic later on for us, and then ultimately she had to undergo an extension to T2. Osteoporotic patients, PJK, they are typically very, very difficult candidates. This is the final patient example which I'm going to show you. And this is a patient who underwent again a T2 to T2 to pelvis, T12 to pelvis fusion. And you see that from this correction to this amount of coronal imbalance to that required a huge lot of steps to be overcome, wound healing problems, osteoporotic fracture at L5. So she went out into a proper, stable fixation and a better quality of life only after 6 months. I will skip this example because I think I'm running late. So avoiding complications would basically means that patient selection is the first key to avoiding complications. Compulsive preoperative planning and exacting surgical techniques are extremely important. Complications are inevitable. However, patients with minor or transient major complications can still have favorable outcomes because an aggressive treatment of complications is very important. So for patients with severe cobangular imbalance, long fusion should be carried out whatever with or without osteotomies to minimize adjacent segment disease. However, the complication rates are high. For patients with lesser Coben imbalance, limited fusion L2 to S1 or T2 to S2 is indicated. And lastly, MIS techniques, OLIF, LLIF, ACR, and staged anterior posterior surgeries may play a key role in the decision-making process. Thanks for the opportunity.
Thank you very much, Dr. Bashu, and for a very excellent and elaborative talk. You know, the tips which you have given, it is extremely important. And in the last few slides, what you have mentioned, medical, medical, and medical. That is the, you know, optimization of the patient is extremely important. I thank you very much for an excellent talk. I have actually
Thank you, sir.
asked all the participants to write questions on the chat box. So while this Dr. Bhauk girl talk is going on, you can go through that, and we'll take question answer session at the end. Thank you very much. Thanks a lot. Now I'll invite Dr. Bhauk girl. Is Dr. Bhauk is available? He was there. Yeah, yeah. Okay. So Dr. Bhauk, are you going to speak, or it is the recorded talk which will be played?
So there's a recorded talk.
Okay. So I will request Jitendra to play Dr. Bhauk's record. Before that, I have opportunity to actually introduce Dr. Bhauk girl. He is professor of orthopedics in AIMS Delhi, a very talented young spine surgeon. And actually, I have witnessed many surgeries which he has performed in AIMS. Recently, we had an operative course. An excellent human being, a researcher, and he has lot to do in future. And actually, ASSI has a lot of hope in him, and I think he is going to flourish more and more. He is going to talk on pediatric spinal deformity. Now, the pediatric patients, they have some specific issues when we take them for surgery, and Dr. Bhauk Garg is going to elaborate. Thank you. Thanks a lot, Dr. Bhauk. Welcome. The audio is not proper. Jitendra, can you make the corrections, please?
Sure, sir, sure.
Audio is poor.
Basically, we can divide pediatric spinal deformities broadly into two categories. When the spine is curved sideways, we call it as the scoliosis. That is, it is curved in the coronal plane, or if it is curved in the sagittal plane, we call it as kyphosis. So broadly, there are scoliosis and kyphosis, pediatric deformities. However, both of them can coexist as well. If we divide the scoliosis further, especially the pediatric scoliosis, we can divide them into early onset scoliosis and late onset scoliosis. Scoliosis, if the age of onset is less than 10 years, regardless of the etiology, we call it as early onset scoliosis. And it can be divided into the idiopathic variety when there is no cause, which we know as at present, or which is secondary, which are not idiopathic, and there are wide variety like congenital, neuromuscular, etc., syndromic, etc. The problem with early onset scoliosis is that in the pediatric age group, because of the growing age, so if there's a scoliosis, that it leads to the shortening of the trunk, and it leads to disproportionate body habitus, which leads to reduced sitting height, and this further leads to the underdeveloped thoracic cage. And these patients, they often develop the respiratory problems, which we call as, in severe varieties, we call them as a thoracic insufficiency syndrome. And then secondarily, it can lead to the cor pulmonale, the heart failure. And sometimes it can be associated with neurological compromise and spasticity. And this early onset scoliosis is basically a heterogeneous group, because I told you that there could be many causes behind it. So the natural history is also uncertain. So the natural history, that how this early onset scoliosis is going to behave, depends upon various factors, which basically can range from the underlying etiologies like congenital, neuromuscular. They tend to progress very fast. The age of the patient, the younger the patient, the faster is the progression. The gender, the females, they usually tend to have more severe disease. If there are associated intraspinal cord anomalies, which are fairly common in this group of scoliosis, they also affect the treatment as well as the chances of progression and the location of the deformity. You know, the whether it is at the dorsolumbar junction or the dorsal in the dorsal spine, they also affect the progression of the deformity. Now, if we can further divide them into infantile and the juvenile types, especially if there is idiopathic scoliosis, depending upon the age of the onset, and the less than 3 years onset, the 12 to 33% of these cases they resolve spontaneously. However, the other cases they tend to progress faster and they can require surgery. So how pediatric deformities they are different from the adult deformities, because there is a strong variability from patient to patient, and the growth potential is very important in this type of pediatric scoliosis, because this is what it differentiates it from the adult deformity, because the growth it can lead to the disastrous consequences in this sort of scoliosis. So there is a domino effect on the thorax. We discussed that, you know, there is in early onset scoliosis leads to the shortened height, which leads to the low lung volumes, low vital capacity. The respiratory muscles are also weak, and it leads to the hypoxemia, cor pulmonale, and poor growth and exercise tolerance, and ultimately it can lead to the respiratory or the cardiac failure. So we know that in first 20 years of life, there is a non-linear increase in the lung and the thoracic volume. But if there is a spinal deformity, this leads to the altered lung and the thoracic cavity growth. At birth, the thoracic cavity is actually 6% of its spinal size. And at 10 years, it reaches up to 50% of capacity, which is essentially required for the normal functioning of the adult this thing. So this 10 years age is actually very crucial. And we know that the shape of the thoracic cavity also changes with age. The number of alveoli, they are same at the time of birth as the adults. However, the multiplication of these alveoli, it increases by 10 times till the age of 5 years, and it stops at the age of 8 years. So again, these 8 years and the 10 years age, they are very important when we are dealing with these patients. So what is the length which we are aiming for? So people initially looked at the T1 to S1 length, that ideally it should be, you know, up to 45 centimeter of the range. But the more important is the T1 to T12 height. Now, if it is more than 20 centimeter, then we can say that the thoracic cavity is sufficient that the child can lead a normal adult life. So this T1 to T12 height, achieving 20 centimeter of height is very important, and it remains our aim whenever we are dealing with this early onset scoliosis. So this is the same thing which I just discussed. So if we intervene early in this age group and we correct this deformity early, that means we fuse the spine early, then it will reduce the chances of the height progression in this thing. So again, this remains a challenge, and there is a further challenge, because if we are doing the surgery from the posterior aspect, which is the most common type of doing the surgery, then it can lead to the continued growth anteriorly, and it can lead to the crankshafting of the spine also, which is again fairly common. Like you can see here, this child, this was operated from the back initially, but actually the anterior aspect of the spine, it keeps on growing, and it leads to further more severe deformity in this child, after some time. Now, there is another variety called congenital scoliosis, when there is a structural defect. Now, the structural defect can be because there is a failure of formation. So you can see here, like there is no formation of the vertebra in this half. So there is only one vertebra, half vertebra, which is fault. We call this hemivertebra. Again, this can lead to the deformity, or if there is a failure of segmentation. So you can see here that all the vertebra, they are fused here. So this segment is not growing, and it is only growing from the posterior aspect. So this can again lead to the deformity, and there could be mixed varieties when both of these issues they coexist in these deformities. Now, whenever these sort of patients they come to us, our aim remains that we have to prevent the progression of the deformity. That is the most important aspect. We have to achieve the physiological spinal alignment so that the head is centered of the pelvis, with as short as fusion as possible, because we do not want to disturb the growth of the spine. So we have to identify the high risk curves. We have to recognize that if there is any subtle progression, we call these patients usually at 6 months interval, and we check whether there is any progression or not if we are treating them non-operatively. And we have to intervene early so that before there are secondary changes in the adjacent normal vertebra, so they can lead to the compensatory curves formation. So again, we have to intervene early before these changes develop. Always we have to rule out the associated spinal cord, the central nervous system, or the other systemic abnormalities, because there is a very high incidence of the genitourinary system problems, kidney problems, and the cardiac issues in these patients also. So we always advise, the ultrasound, KUB ultrasound of the abdomen, and the echo to rule out the associated abnormalities. Now, decision making for these sort of the hemivertebrae or the anomalies, this depends upon their morphology, their location, their growth potential. So if a vertebra is fused on one side, then it has got less potential. If this vertebra is open on both the sides, then there is higher potential, and how the spine is balanced. So there are different criterias by which we'll look at, and this is a table which can help us, by looking at the chances of progression of different type of congenital scoliosis. I'm not going to detail. The more important for a general practitioner is that that we should be aware of their evaluation, that how do we evaluate them preoperatively. We should be very thorough and systemic. A complete neurological examination is a must. We have to rule out the intraspinal anomalies, and usually if there is any doubt of any neurological abnormalities, we should get a whole spine, the MRI, including the CV junction. So complete imaging is a must, especially if there is any evidence of any skin stigmata, if there is any cephalot spots, if there are any the tuft of hair, or if there is dimple in the spinal region, in the region of the spine, or if there is a neurological deficit. The MRI is to basically to rule out the intraspinal anomalies. In adolescent idiopathic scoliosis, that means if the scoliosis is appearing after the age of 10 years, usually it is not required if we are not treating them operatively. However, it is a must in certain situations, like suppose if there is a left-sided thoracic curve, if it is a rapidly progressive curve, if it is associated with kyphosis, if there is a back pain, if there is a history of headache, and if there is an abnormal neurological examination. So these cases, they warrant that the MRI should be done of the whole spine, including the CV junction. Now, whenever we are waiting for these patients for surgery, we are not, even if we are treating them non-operatively, when we are not sure whether they will require surgery in future or not, we have to prepare them for surgery. And most of the time, these patients, they are very poorly malnourished, so we have to give them protein supplements. We give them hematinics, calcium, vitamin D supplementation. We have to correct the underweight if they are very severely malnourished. Then we have to take the opinion of the pediatric surgeon to put the feeding jejunostomy tubes, etc. We have to assess their pulmonary function, cardiac reserve. We ask them to do incentive spirometry exercises, deep breathing exercises. More important is to do counseling of their parents, because the children may not be aware of these problems, but we have to, the parents, they're quite worrisome, and we have to do a proper counseling. We have to explain the risks involved. We have to explain our surgical goals. The need for surgery depends upon that how big is the curve at the time of presentation, and how big it can be depending upon the type of the curve which we are presenting. Now, whenever these patients, they come for surgery, as an orthopedic surgeon or any general this thing, we should also be aware of the various anesthetic considerations, that what problems they're going to face. We have evidence now that the anesthesia can affect the long term, the psychological outcome in pediatric patients. And nowadays, because we do these surgeries under neuromonitoring control, then the normal inhalational general anesthesia we do not use. We use the total intravenous anesthesia, and there are special drugs available by which we can modulate the neuromonitoring control also. And we use targeted control infusion to maintain the concentration. So there are various aspects of the anesthetic considerations also which we should be aware. Now, coming to surgery, just a little bit glimpse that the surgery is also possible, and surgery has got good results. There are some conditions in which we intervene early, then we can just a short surgery we can get away with the problem. Like if this is a small hemivertebra which I discussed with you, we can just take it out with a short fusion, we can get away with it, and there is no major impediment to the growth of the child. And like this is another example of a case, and you can see here that initially in the immediate postoperative period there are some compensatory curves available, but with growth they also tend to correct fairly good. And sometimes there is associated sensitive file problems also. They also tend to correct with the growth if you remove the primary problem. The lumbosacral hemivertebra, they are again, you need to intervene very early, and they should be referred to the appropriate surgeon very early, because the whole foundation of the spine gets shifted to the other side, and this can cause long-standing problems. They should be dealt very early, and if you deal them with early, then you can get very good results immediately. If there are several vertebrae, multiple hemivertebrae, then we have to go for special growth-friendly constructs are available, and either or we can choose the definitive treatment also. So these are some sort of growth-friendly implants by which we can actually like this is a traditional growth rod by which we place these the special devices called dominoes. Then every 6 months we go inside the patient, and then we distract these rods over them. So then we tend to grow every 6 months till we convert it to the definitive fusion. Now this growth can be can be done with the help of the magnetic growth rods also. These are the special by which with an external magnet we can just lengthen these rods. So again, these are the options. This is just to show you some examples that a traditional growth rod which we have put here. And this is how we do it. We usually expose them proximally or distally, and then we apply our anchors and we put our rods, and we like this thing. And these are some complications you can see here. But again, I told you that the anterior part can keep on growing, so close watch is essential, and they can be a problem with these patients also. And sometimes because we are doing repeated surgeries in these patients, then there are scarring and all those problems also there, and frequently we require the services of the plastic surgeons to help to deal with us these the scar problems when we are going for repeat surgeries. And we can use the tissue expanders or the latissimus dorsi flaps in these patients very commonly. Like this case we have done with the tissue expanders and a more complex surgery. Magnetic growth rods, again, the advantage is that the child is not requiring these repeated lengthening in the operating theater. So there is a non-invasive lengthening, and there is a significant decrease in the number of planned surgeries. And this is available in India as well as abroad. And you can distract up to 48 millimeter with these rods. There are certain contraindications of these things, like the infections or the pathological conditions, or if the childs they're allergic to these patients, if they've got any pacemaker or any other electronic device. Less than 2 years, weight limit is very less, and the patients, their families, they are incapable. Recently, there are concerns with the metallosis with these problems. So you can see here that there's just some of the examples, like the difficult cases which we have done with the help of these magnetic rods surgery with this thing. Another example, very difficult case, and we have done the magnetic rods. Very severe scoliosis. Again, we could get a very good correction, and with the help of these magnetic rods. Post-operative lengthening, how much we do, the ideal interval is not known. In case of traditional growth rods, we usually tend to go between every 6 to 8 months. In magnetic rods, we can be done because it is a non-invasive one, so it can be done more frequently. And usually we start after 3 weeks to 3 months, and we do it under OPD basis. There are magnets locator. I will just show you, like this is a case here. And you can see here that, I think this video is not working, so I'm not going to detail. But this can be done, there are special devices by which we can just place it on the patient's body, and then we can just set that how much lengthening we want to achieve, and then it just lengthens. This external device just opens up the magnet inside the patient's body, and we can use the ultrasound to decrease the radiation to these patients to measure that how much actually the magnet has lengthened the rod inside. We have now evidence that with each distractions, there is a law of diminishing returns. So the lengthening actually keeps on decreasing with this thing. And usually we stop when the patient is skeletally mature. If there is a result, there are guidelines for this thing. If there are some complications, or if the curve is still progressing in spite of putting rod, or if it is not distracting, the failure to distract. So these are the indications. There are various complications also with magnetic growth rods also, like they can break also. And implant prominence, especially in the Indian patients, is again a problem. And this metallosis is a frequent problem. So nowadays, the company itself recommends that, we have to take this rod out within 2 years. So again, this is defying the purpose, because these rods, they're very costly, and we are implanting and we have to take it out within 2 years. So nowadays we are not using them, and we are using actually a different modifications of this thing, which I will just deal later on. Neuromuscular scoliosis is again a problem, this thing, and they are usually, the bones are weak, the anchors are weak. So in non-walkers, we have to go up to the pelvis, so which has got its own set of complications. A fairly commonly asked question is whether we can use the MRI for these children if there's a magnetic rod inside. So there is, the studies have shown, and in fact, we are doing routinely the MRI in these patients, and there are no problems of using the MRI in these patients. Now, there are certain other surgical, the modifications of these technique, like, we can just fix proximally and distally, and we can leave these screws open. The rods, they can slide over these screws, and we can just fix them at the apex. So these are called Schiller techniques. Like you can see here in this curve, we have fixed it at the apex, and we have left it to grow at the proximal and distally. So again, these are, some sort of growing rod techniques. We can also use modifications of, just distracting the lungs. If there are rib fusion, we can cut the rib, and then we can put a distraction device. So it also helps in growing the thoracic lung volume. But again, these are these things. So this is again a modification of the further growing rod technique, or you can Sheila, which we are now commonly using, which is like we don't have to go repeatedly inside the patient for doing the lengthening in this case. And we have captured the apex here, and we keep these rods free here actually. And so these, with growth, actually they keep on growing inside the rod. So we have to just monitor it, and we don't have to go inside. Sometimes we, like this another example, sometimes we are also combining it with the help of the magnetic rods. So we just distract on the concave side, and the other side it just keeps on distracting itself. And you can see here that with a minimally invasive technique, we can do these sort of surgeries. There are some other, the modulation techniques, the growth modulation techniques also. People are using the tethering techniques also, which I personally have no experience, but again, it is coming up a big way. So what are the problems if you don't treat them early? If you don't treat them early, especially these congenital varieties, then they tend to present later on with very, very severe deformity, like you can see here with a very severe deformity here. And then you have to deal with the larger and the stiffer curve. There are secondary changes in the normal vertebra, and these require, the more invasive surgeries, the osteotomies, like you have to cut the spine above and the below, and you have to just then join them again in a different, in a corrected position, which can lead to the greater blood loss, surgical duration. The neurological risk of paralysis is also more, and these patients, they also require the longer fusions. So like this here, this is a very severe curve, and we have also come up with a specific surgical technique for dealing with these sort of problems. So you can see here that we have cut everything inside. Again, this is a very, we call it as a vertebral column resection, and there are several modifications by which we can do these sort of surgeries. This is just to show you the pre and the postoperative outcome. Again, like I told you, the lumbosacral problems, they can be very severe, and they can, like, these sort of, the whole of the spine is shifted to the one side, and they again require these severe deforms, the very risky surgeries. Like another case in which we have to do a vertebral column resection here. Another very severe case, these lumbosacral varieties. Now, the problem with the cervicothoracic, if the deformity in the cervicothoracic, is that they can become very, the painful, especially because these ribs, they can touch the pelvis, and this can be a very source of very severe pain in these children. And also, this child, the scapula is touching the mandible actually. And this can be again either the mandible or the skull, and they can be again a source of very severe pain in these children. And these cases, they require very severe deformity, very, the very major surgeries to correct these sort of deformities, which again has its own challenge. So one should try to catch them early and intervene early, especially if you see these sort of problems. Coming to the adolescent idiopathic scoliosis, when the growth is relatively, a little bit complete and between 10 to 18 years of age, and it is the one of the very common type of scoliosis which is seen. And these are basically diagnosed of exclusion, and there can be there are various varieties of this thing. There are various classification of these things, and we usually rely on the Cobb's angle, which is an angle between the most tilted vertebra into the curve. And we look at these bending films in these things to look at the flexibility, and there are criteria by which we decide that what should be our levels to correction, which we use. Treatment depends upon the Cobb's angles, however it is not absolute. So usually if the curve is between 10 to 30 degrees, then we tend to just observe these cases every 6 months. We get the x-rays till their growth is complete, and we put them on certain exercises, scoliosis exercises. There are several like short exercises and the specific exercises which we prescribe to these patients. If the Cobb's angle is between 30 to 45 degrees, we usually give them bracing, and if there's more than 45 degrees, then we usually tend to go for the surgical intervention. Now, bracing is very, very important, and there are several types of braces available in the market. And again, we have to, more important thing is the compliance, that the patient should wear them, and the ideal recommended duration is that they should wear at least 23 hours a day out of 24 hours. That means they have to sleep with the braces on, that if you want to get the full advantage of these braces. If it is more than very severe curve, more than 45 degrees, then we have to go for surgeries, and the surgery is with the help of these modern techniques and the neuromonitoring. The surgeries are quite safe and quite satisfactory. Coming to the second type of deformity, a pediatric deformity, which I discussed, the kyphosis is a sagittal deformity and is a more serious and the more risky surgeries than the scoliosis, and it can be secondary to tuberculosis, which is the most common cause of these kyphosis in our part of the world, and congenital ankylosing spondylitis and miscellaneous varieties like this. This is a syndromic Marfan syndrome, and these can be these are usually relatively easier to correct as compared to the post-tubercular deformity, where you have to pick up you have to look every child who is presenting with the tuberculosis, that there are certain risk factors by which you can predict that how much this deformity is going to progress. And should be this child had tuberculosis, and she presented to us with 115 degrees of kyphosis with a healed sinus here, and you can see here that her D7 to L3 is fused in a single mass, and these sort of deformities, they require very severe correction and the surgical techniques to get an optimal outcome. And the ankylosing spondylitis patients, again, in our part of the world, they are severely neglected, and they can lead to and they are different problems than the tuberculosis and all these congenital ones, because they are global problems, and you have to take into account the certain parameters, the global sagittal balance, the pelvis, the knees bending, and then you correct these sort of deformity. And like these cases, they require extensive planning with the help of special surgical softwares, and how much correction is to be done, where is to be done, and then we plan our surgery. And like in this case, we have to go for very severe correction at 2 levels, and we could get a good correction. So to summarize, these pediatric spinal deformities, they are very challenging conditions to treat. The role of observation, casting, bracing, and various forms of surgery are there. We have to think of, if we are going for definitive fusion before skeletal maturity, then we have to think of the problems with the shortening spine and the lung problems. So always there is a dilemma between the need to correct the scoliosis and the impossibility of performing fusion, especially in terms of the growth restriction. And there are various types of surgical procedures available. We haven't found the holy grail yet, but yes, there are some certain procedures which you can get the satisfactory outcome in these pediatric scoliosis patients. Thank you.
Thanks a lot, Dr. Bhav, for an excellent and very informative talk. I'm not finding any question in the chat box. I think one question for each faculty I would like to place. First with Dr. Bhav. What is the role of corrective cast in pediatric spinal deformity? I think you did talk about the bracing and all. So role of corrective cast. Sometimes the child is small, you want to further increase in height and you wait. So earlier, all these practices were quite useful earlier also. And Min Mehta is one of the proponents of this. So what is your opinion regarding this casting?
So the cast is again remains a very useful tool in our armamentarium, and we like the child, if it comes in very early stages, especially in less than 8 years of age, when we usually tend to avoid doing surgeries unless it is absolutely necessary, then in those cases these castings and the bracing, they remain very useful. And the casting, there's a specific the method which we call as the EDF, the elongation derotation cast, is very good technique, but it requires under general anesthesia. And if something is a very high volume center, then it becomes a problem, like for us challenge to schedule them for the surgery, and every 3 months we have to change it. So again, this remains a challenge for us too. So usually commonly we resort to bracing, some sort of bracing also, because there are a lot many the scheduling of these patients remains a problem, but again it's a useful tool.
And another question for Somajit. Again, very interesting and very elaborative talk Dr. Somajit has presented to us, and very informative. So another single question to him. We talked that when it becomes too much and when it is too less. So even if you go to Germany, you find one center is operating, from T1 to S1, and another center which is doing very limited job, but still patient is happy. There are a lot of degenerative changes which is visible, but sometimes you find you did a very minimal thing, and patient who was very much symptomatic has become asymptomatic, and we actually try to postpone that lengthy procedure. So indirectly, what I'm trying to ask, the role of local blocks like root blocks, facet blocks, that part, if you could elaborate a little bit.
So, thanks, Dr. Srivastava, for asking me this question. Um, I think selective nerve root blocks comes in the purview of conservative care. So, as I had initially mentioned, that none of the patients of adult deformities are admitted into an operating schedule in our center without a prolonged conservative trial. And many of these do so well with local blocks, especially if these patients have radiating leg pain, which is basically because of root canal stenosis. They have excellent relief with root blocks. And at least if I have, uh, I'm seeing 10 patients for surgery, at least 3 or 4 of them would disappear with prolonged conservative care, including root blocks. The second utility of root blocks is the fact that they can localize the pain generator so well. And many of these patients who do not do well at all after a root block, we have serious considerations for giving surgical options to them, because there are many patients who basically have fibromyalgia or who have some elderly degenerative neuromuscular disorders like Parkinsonism, or they have some dementia problems, which gives rise to the typical PISA tower or the leaning spine. And all of these patients can be excellent, very well ruled out by selective root blocks. So I agree with you that selective root blocks are really very useful tool for treating adult spinal deformities. In continuation to Dr. Bhabuk's statement, I think that's the only thing which was uncovered in his very extensive and very beautifully laid out talk regarding pediatric deformities, is the fact that for the last 5 years, I have stopped using any surgery for any patients less than, other than the short hemivertebral fusions, hemivertebrectomy surgeries for single or two level hemivertebrae. I have not done a single surgery for patients below 5 years or 6 years, and I have resorted to casting. I have significantly been benefited by these patients. I understand that in AIMS it is very difficult to schedule because this is such a huge waiting list of major deformities. And to schedule these surgeries 3 months, every 3 months, means that they will be having half their operative load of casting only, given the volume which they face. But for our private centers, it is much more doable. And I have a lot of belief in casting, especially because of the fact that these patients, once they are braced, their parents are not very keen to go on with correct ways of bracing for 20, 22 hours a day. And non-compliance is a major issue. And the patients develop beautiful affinity to casting. Most of these patients, they are very well suited to casting. They adopt casting. Their parents becomes quite adaptive to this. So I think casting is something which is It is a very good, useful tool in the treatment of pediatric scoliosis.
Thank you very much, Dr. Somajit. Now I am seeing that participants are reducing in number. So I think this was a wonderful academic session, and I thank both the faculties for their excellent talk. And if still there are anyone who is left and wants to ask question, you can go ahead. Otherwise, we will close this session. Any other thing, Bhauk, you would like to speak? And of course, Dr. Basu also.
No, sir, I think everything is covered. Yeah, thank you. Thank you very much.
Thanks for the opportunity, sir.
Thanks a lot. Thank you very much. I thanks all the participants. Now we'll close the session. Thank you very much. Thanks a lot. A very happy weekend. Enjoy Dr. Basu and Dr. Bhauk.